Hi, everybody. Welcome. Thank you so much for coming this evening. It's so great to see your names. We're super excited to get started. We have some awesome content to share with you all. Thank you so much for coming. Hi, it's very nice to see you. So many people popping in. It's great. I love it. I love it. Keep them rolling. It is 7 o'clock. So, we are going to get started on our webinar tonight. And if people start rolling in, that's totally fine too. So let's get started. Good evening, everyone, and welcome to Depression 101, brought to you by NAMI Cook County North Suburban and Dr. Leslie Brankin, a licensed clinical psychologist and director of the Young Adult Mood and Anxiety Program at Compass Health Center in Northbrook. Compass Health Center provides evidence-based, comprehensive, non-hospital-based psychiatric care. Founded in 2011 by psychiatrist Dr. David Schreiber and Dr. Claudia Welk. Compass Health Center offers partial hospitalization programs and intensive outpatient programs at 3 on-site locations, Northbrook, Chicago, and Oak Brook, for ages 5+ and virtually throughout the state for ages 12+. Compass Health Center offers specialty programs for mood and anxiety, OCD and complex anxiety, trauma, mental health and substance use, mental health pain and illness, screen dependence, and school anxiety and refusal. I am Bree Hoekstra, the program director at NAMI Cook County North Suburban. NAMI, or the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization, providing public awareness, no-cost support, and education programs online and in person so that people and families affected by mental health conditions can build better lives. We are the lifeline to individuals and families who do not know what to expect in their difficult life journey. We offer classes and support groups and do a lot of local advocacy for mental health. Our programs are totally free of charge and open to those in our community service areas, but we do not turn anyone away who is in need. We are so pleased to have you all here tonight at our second webinar in our mental health conditions, What You Need to Know series. This year, each month, mental health professionals will dig deep into a variety of mental health conditions to provide further education to raise awareness and fight to end the stigma surrounding mental health. For our topic tonight, Dr. Leslie Brankin will further educate us on depression disorder. NAMI National states depression disorder, or frequently referred to simply as depression, is more than just feeling sad or going through a rough patch. It's a serious mental health condition that requires understanding and medical care. Left untreated, depression can be devastating for those who have it and for their families. NAMI National also states that about 21 million U.S. adults, or 8.4% of the population, had at least one major depression episode in 2020. It is imperative that we take the time to learn more about this common mental health condition so you or your loved one experiencing these types of challenges can get the support they very well deserve. Through this webinar, you will leave with a better understanding of depression as a mental health condition by learning more about the diagnostic criteria and contributing factors, comorbidity and statistics, treatment interventions, skills to manage, and suggested tips on self-care and prevention. We will leave plenty of time for Q&A at the end, but if you have questions throughout, please type them in the Q&A feature on your chat box below. Tonight's guest speaker, Dr. Leslie Brankin, is a licensed clinician, psychologist, and the director of the Young Adult Mood and Anxiety Program at Compass Health Center in Northbrook. She received both her doctorate and master's degree from the Chicago School of Professional Psychology and her bachelor's degree in psychology from the University of Wisconsin-Oshkosh. Dr. Brankin has worked at Compass for over 5.5 years. Prior to Compass, Dr. Brankin's clinical and professional experience has included working in inpatient hospitals, therapeutic day schools, and community health centers. She has a passion for working with young adults, especially as it relates to promoting independence and autonomy throughout the transition to adulthood, while navigating the stressors that are present for this age group. Recognizing the need for support related to launching to college and managing mental health concerns, Dr. Brankin also helped to facilitate the creation of a college preparedness program for young adults at Compass Health Center. She has presented to the community on such topics as school refusal and problematic outcomes of excessive screen time. She has provided supervision to graduate students and greatly enjoys taking part in the training and onboarding of future clinicians. Dr. Brankin also manages her own outpatient private practice. We are so thrilled to have her here tonight to further educate us on this ever important topic. So I am very honored to welcome our guest speaker tonight, Dr. Leslie Brankin.
Thank you so much. Let me go ahead and I will start sharing my screen. Okay, so thank you again, Bree, for that lovely introduction. I am incredibly thankful to NAMI for hosting this webinar and looking forward to spending the next hour or so with you. I do want to preface that this presentation, there is a lot of information in the literature and in the research on depression due to how prevalent it is. So I say that because unfortunately, in the short time that we have together, we will not be able to uncover and talk about every single thing. But with that said, my hope is that you do walk away from this presentation reflecting on the impact that depression also has globally, and then also finding value in the resources and references throughout the presentation. So with that being said, the things that we are going to cover tonight. Here is the presentation agenda that Bree had gone over. So I'm going to do a bit of an overview, talk a bit about diagnostic criteria and contributing factors, comorbidity and statistics, treatment interventions, skills, and then of course, self-care and prevention. So before we get started, I do think that's important to talk about just a moment of reflection. And when we think about the impact that depression has globally, I'd like everybody in this virtual room to think about ways in which you have witnessed somebody personally struggling with depression. So whether it's yourself, a family member, a close friend, a partner, also potentially for clinicians that might be in this room, thinking more so about how many have supported patients and their depressive symptoms. And I start with this reflection because of the impact that depression has had and continues to have on a wide variety of individuals. And that's what we're going to talk about today. So first and foremost, I want to start with some statistics. Okay, so as Bree had mentioned, depression impacts close to 21 million adults in the United States, which is the equivalent of 8.4%. Globally, according to the World Health Organization, that is 280 million individuals. If we break it down further to our youngest age group, right, adolescents, 12 to 17, 5 million adolescents have been impacted by a major depressive episode. The most impacted age group, one that is near and dear to my heart, having worked here at Compass in the young adult program, is that population. And that is 18 to 29%. I'm sorry, 18 to 29 years old, 21% of that age group that is impacted by depression. The second most impacted is the age group of 45 to 64. Approximately 39% of individuals with symptoms of depression do not seek treatment. And I think that's why this presentation is even more vital, is talking about the ways that we can support others, the ways that we can support ourselves, and resources that are available that folks might not know about. When we think about the symptom severity of depression, we often categorize it by mild, moderate, and severe. So mild cases impact about 11.5% of individuals, moderate 4.2%, and the highest severe is about 2.8%. 50% of all lifetime mental illness begins by the age of 14. And throughout this presentation, I will talk about the impact of depression on specific age groups as well. So, talking a little bit more about the global impact, right? So depression is truly something, this is a quote, and it's a quote by Dr. Shaw. He's at the Menninger Department of Psychiatry and Behavioral Sciences. And he says that depression is truly something that will manifest differently in different cultures. Culture will change the meaning of the depression, so we won't always see the same kind of symptoms present themselves. And this is very important when we think about how we're interacting and how we're holding space for individuals. When we think about that moderate to severe range of symptoms, those are often most reported by folks who identify as more than one race. Depression is lowest amongst Asian adults compared with Hispanic, non-Hispanic, and white adults. Globally, 4 out of 10 individuals ages 15 and up have either experienced depression or witnessed it within somebody close to them. And I wonder too about whether or not this number is actually higher. This is from a Gallup study of 2023. However, that's just the people that have reported it. So I could actually imagine that the number is quite more significant than that. The other thing to keep in mind when we think about global considerations of depression are the availability of resources and support. Are individuals seeking care? Are they seeking support for management of their depressions? This absolutely has an impact on the outcome of that. We'll also talk a little bit about the COVID impact. It's hard to imagine, believe it or not, that COVID was 4 years ago, but we are absolutely seeing the residual impact of that on individuals who are diagnosed with depression. We see that social isolation, the loneliness, the fear of infection that people felt during that really heightened period of COVID, the psychological exhaustion, whether folks were working from home, the transition to virtual. Elevated substance use also occurred during this time, and significant disruptions in mental health services. All of these factors combined led to a huge spike in depression. And as I had mentioned, we're still seeing the fallout of that today. That elevated loneliness that also occurred during COVID led to chronic and pervasive depressive symptoms too. So what I want to transition about, now that we discussed, the overarching statistics, the impact, I want to break it down a little bit more. And I want to go through the specifics of each of the depressive disorders that are listed in the DSM. So the ones that I'm going to focus on today are disruptive mood dysregulation disorder, major depressive disorder, persistent depressive disorder, premenstrual dysphoric disorder, substance and medication induced, and then other specified. So when we think about the impact on our youngest age range, right, I want to start with disruptive mood dysregulation disorder. So this is really for a diagnosis of depression that occurs with our youngest population. So the age of onset for this is before 10, but not before 6. So really 6 to 10 is that window. And the core feature of this that we're often seeing in these younger children is that chronic, severe, and persistent irritability. One thing that I mentioned a few bullet points down is that it's inconsistent with the developmental level, right? Like this is more extreme. This isn't just the young child that might be a little bit irritable or, have a temper tantrum here and there. This is more of an extreme type of behavior that we're seeing with this. Additional symptoms for disruptive mood dysregulation disorder, or DMDD for short, is severe recurrent verbal or behavioral outbursts. So verbally lashing out, throwing things, destroying property, irritability, and also anger most of the day. It has to be observable by other people in order for this diagnosis to be present. Further, we also have to have these symptoms that are presenting in at least 2 settings. So whether it's happening at home, whether it's happening at school, or whether it's happening on play dates for these individuals, it has to be in at least 2 of those settings. Additionally, the time frame, it has had to have been going on for at least 12 months without any absence of symptoms for more than 3 months. It's also happening a minimum of 3 times per week. When we think about prevalence, right, it has been stated in the research and the literature that about 2 to 5% of these children, of children in general, will be diagnosed with this disorder. It's higher in males, and it's of course higher in school-aged children. There are some co-occurring conditions to think about too: attention deficit hyperactivity disorder, other anxiety disorders, depression in general, all of which might be perpetuating this as well. Other things: low frustration tolerance. These are the kids that, if they are, not chosen for an activity, they might completely decompensate, right? They might be the ones that, refuse to participate in the classroom, or, throw their items if they are getting upset on an activity within the classroom. Ones that might not be able to tolerate play dates, right? School performance is often impacted as well and might lead to potential for hospitalization at some point. So that is the first of the depressive disorders that we'll talk about related to our youngest population. The next is major depressive disorder. So I think this is the one that we often hear the most of in the literature, right? And so when we think about this, the time frame for this disorder is that it has to happen at least 5 or more symptoms within a 2-week period, one of which that is being experienced nearly every day. I highlighted the first 2 bullet points because one of these must be present. So either they are depressed and experiencing that most of the day, nearly every day, or there's a marked diminished interest or pleasure in their activities. For children, this often presents as irritable, right, as we had talked about before. And when we think about that diminished interest, like that lack of interest in hobbies or social withdrawal, previously having an interest, maybe they used to, play soccer, or they were interested in sports, or they were an avid reader. And now those things are just not of interest anymore. It's almost like they can't even drum up enough energy to engage in those things. And so we have to see one of those first 2 bullet points present. The rest of the bullet points, we have to see at least 4 of these features present. So fatigue and loss of energy is actually often the first symptom reported. There's also psychomotor agitation or retardation, and this is either feeling super restless and keyed up, or feeling really, really slow, kind of like you're slogging through mud. If even though these are less common symptoms, they're also a greater indicator of there being a greater severity of a depressive disorder. We often see weight and appetite changes, so eating more, eating less, sometimes craving certain foods might be present with an individual that has a major depressive disorder. There is also significant impact on sleep cycle and sleep hygiene. So we talk about insomnia and hypersomnia. So trouble falling asleep, trouble staying asleep, waking up a lot throughout the course of the night, napping frequently throughout the course of the day. Those are often things that we see with this presentation as well. Further, feelings of worthlessness and guilt, attention issues, indecisiveness. Sometimes we call it decision fatigue. So being unable to truly make one more decision. We often see that as well. And we'll talk a little bit more about risk issues, but there is the recurrent thought of death and suicidal ideation, oftentimes present, but not always, with this disorder. We break it down between passive thoughts and active thoughts, and I will talk a little bit more about that in a few slides from now. When we think about major depressive disorder, we're really thinking about that age of onset. It sometimes increases during puberty, but really the peak is in the 20s, which is why, going back to a couple of slides ago, we really see that impact on that young adult population. It must cause an impairment in daily functioning for this to be diagnosed. Oftentimes, as I mentioned above, that fatigue, body aches, headache, sometimes individuals are presenting with more somatic complaints. Descriptors are often, I'm feeling down in the dumps, or I'm discouraged, I'm hopeless, I just feel blah, or not really even being able to access their feelings. Prevalence-wise, 7% of all individuals in the United States are diagnosed with a major depressive disorder. And again, these numbers ebb and flow, but that is most recently in the research. And it is more common in the female presentation. And again, I will talk more specifically about differences with males and females and how depression presents for those different populations. Remission typically doesn't occur, but if it does occur, it's when you go at least 2 or more months with no symptoms. There are certain specifiers, right? So when we think about a major depressive disorder, we're then classifying it potentially even further, right? Is this an individual that has a primary depressive disorder, but there's also anxious distress, right? Restlessness, worry, feeling out of control. Additionally, mixed features, so manic symptoms or elevated self-esteem, talking really, really fast, having more energy than might be normally witnessed or experienced. There's also the melancholic features, right? So just that sluggish, lack of interest, agitation, maybe a worsening mood in the morning, not having any interest in former activities. That is also a specifier. We also think about atypical features with depression. So this is one in which the mood might improve by happy events, but it is temporary, right? Like it is not long-standing. There also might be an increased need for sleep, increased appetite, an overall sensitivity to rejection, a heaviness or a feeling in the body. That is more of what we would look for with an atypical presentation. Psychotic presentation is exactly what it sounds. This is where we might experience or see hallucinations or delusions. And lastly, I'm sure folks have heard of seasonal affective disorder. It's right now, there's a lot of research on it, especially during this time of the year. But really, we are seeing the mood, the depressive mood impacted by changes in seasons, and of course, that decreased sunshine. So when we think about all of the different factors of depression and all of the symptoms, we are also looking for these specifiers. So I want to keep going to our next one, which is persistent depressive disorder, formerly referred to as dysthymia. So this, when we think about this specific depressive disorder, we're thinking about more of a chronic condition. So the time frame for this is that depressed mood. It happens most of the day, more days than not. It is ongoing at least for a minimum of 2 years for adults and a minimum of 1 year for children. So this is way more of a time frame when we think about this compared to a general depressive disorder. The symptoms are listed below, similar to what we've discussed for a major depressive disorder, but 2 of these must be present, all of which are the same as we've mentioned previously. The age of onset, they classify it between early and late. So early onset is before the age of 21, and after age of 21 is considered late. 2.5% of individuals are oftentimes diagnosed with a persistent depressive disorder. Moving on to the next one that we will discuss is premenstrual dysphoric disorder. And so this is a disorder that occurs related to depression before, in which 5 symptoms have to be observed or experienced before the onset of their cycle. Also, it starts to improve a few days after the onset of their cycle and then would become minimal or absent in the week after. Really, the age of onset for premenstrual dysphoric disorder, which again is one of the depressive disorders, it can occur at any point after the first occurrence of menstruation. The prevalence rate for this is 1.8 to 5.8% of menstruating women. There are considerations, though, to keep in mind, and some of those considerations are the environmental factors, right? So stress, trauma, seasonal changes, the female gender role in general. Genetic factors also play a role in this disorder. So upwards of 50% may have this disorder if there is somebody in their immediate family that does, such as a mother or a grandmother or a sister. And there are also cultural factors to consider with this one. This is not something that is just bound to the United States alone. I did put a listing of all of the different symptoms below. And so, we think about the general, symptoms of a depressive disorder, but then also with this one is that feeling of being overwhelmed, feeling out of control, Also maybe increased irritability, maybe seeing more conflict with a spouse or a partner. Additionally, having decreased interest and concentration issues presents with this disorder as well. Okay, moving right along. We also have a category related to substance and medication-induced depressive disorders. So the core feature of this subset is involved with the ingestion, injection, inhalation of some sort of substance or medication. So for the symptoms, it has to be a prominent and persistent disturbance in the mood, right? So there is the depressed mood, and then there is a diminished interest and pleasure in all activities. And there is evidence to support that this is developed immediately following the taking of a substance or the taking of a medication. And as similar to all of the ones that we've described thus far, there has to be a significant impairment in daily functioning. The time frame in this part is really important when thinking about the potential for this as a diagnosis, is that it has to occur within 1 month following the use. So whether it's the substance or taking a medication, typically symptoms will be seen within 1 month following that. Prevalence is about 25-ish% of the US adult population that might experience a substance or medication-induced depressive disorder. I do want to note just a few other ones, that we might often see, and we refer to these as the other specified depressive disorders, and there's 3 of them. The first of which is like recurrent and brief. So the symptom list that we've gone through throughout the course of this presentation, 4 of those symptoms must be present for 2 to 13 days. Happens about 1 time a month for a minimum of 12 months. Additionally, there's the short duration depressive episode. This is 4 symptoms for a minimum of 4 to 13 days. And then a depressive episode with insufficient symptoms, right? So this is one where we're seeing that depressed affect and maybe 1 symptom for at least 2 weeks. Typically with this, we're trying to gather more information about what might be going on. But important to note that there are these other specified depressive disorders that fall into that category. Okay. So when we think about all of the ways that depression can present itself, it's also super important to discuss the co-occurring issues that might also be going on. So I broke this down into medical and mental health related issues, right? So individuals are more likely to seek out medical care versus mental health support. So that goes back to what we had shared a couple of minutes ago about, presenting with fatigue, or I feel like my body aches, or something along those lines. They're more likely to go to their general medical doctor first versus seeking out mental health support. Those that experience cardiovascular or metabolic issues are 40% more likely to develop depression. 33.5%, or the equivalent of 19 million, will also experience substance use disorders in pairing with depression. Heart attack, 40 to 65% of individuals will experience depression. Stroke, similarly, although less, also occurs depression in about 10 to 27%. Other things to keep in mind medically that might be co-occurring at the same time are diabetes, obesity and weight concerns, potential eating disorder issues, thyroid and vitamin deficiencies also are important to potentially rule out. When somebody presents with a depressive disorder, oftentimes we're also seeing that there might be an anxiety disorder. We might potentially be ruling out for whether or not there's a bipolar disorder, substance use issues, which I've mentioned a couple of times, and also the potential for personality disorders. I want to go back, as we finish up talking about the different segments of depressive disorders. I do want to talk about what it means to assess for risk, because while suicidal ideation it doesn't happen in every single individual, it does happen in a majority of individuals, and it is important to know what it is that we're looking for. I do want to preface the National Suicide Prevention Hotline number, which is 988, and this is a great resource for individuals that might be struggling. But when we think about assessing for risk, when we think about somebody that comes in, with a depressive disorder, whether it's one of the 6 that we just talked about, or if we're trying to get more clarity on symptoms, we are assessing for whether or not they are a danger to themselves, right? And we're looking at these 4 different categories. So their mood, communication, behavior, and whether or not there is any planning, means, or verbalized intent to harm themselves. So are they presenting with lower energy or worsening symptoms? Have they shared that they feel worthless or hopeless? Have they discussed being a burden to other people? Are they writing or researching things that are related to death or suicide? What about behavior, right? Are they engaging in high risk and impulsive behaviors? Oftentimes we might see just this disregard for their own safety or the safety of others. Are they speeding down the highway excessively? Are they engaging in risky, potentially promiscuous behavior, not really caring about the outcome? Are they putting themselves in other sorts of dangerous situations, not really caring about the outcome? Substance use, of course, also falls into that category. The other, component that we are assessing for is whether or not there is planning, right? Are they giving away their possessions? Have they potentially written a letter? Is there any other references or observations of preparation? Those would all be serious concerns that an individual obviously needs more support, and potentially a higher level of care, which we'll talk about that in the course of the presentation as well. Additionally, hospitalization, if they are clearly a danger or a risk to themselves, we want to ensure they are getting that level of support that they need so that they can keep themselves safe. Moving right along, I want to talk also about contributing factors. So we've given an overview of the depressive disorders. We've talked about the co-occurring issues that might present themselves. We've also talked about the assessment of risk. So knowing those things, what are some factors that might contribute to an individual being diagnosed with depression? There are a few different categories that I want to talk about this evening. First of which is brain changes and things that are happening in our brains, traumatic experiences, genetics, life stressors, and medical and substance use issues. So I want to go ahead and break all of those things down. And again, I want to preface this by saying there is so much information in the literature on all of these contributing factors. But for the sake of this being a 101 presentation, I did want to just do a glean over. But please know there is a lot of information available. So when we think about what happens in the brain when an individual is depressed, right? That depression is resulting from a chemical imbalance. Something is happening in the brain that is imbalanced, right, or off balance. And so we think about three different parts of the brain that have an impact on this. And so the first of which is the amygdala. And the amygdala is associated with our emotions, right? So that anger, pleasure, sorrow, fear, and arousal. Activity here is actually higher when a person is sad or depressed. We also have the basal ganglia, and this helps to facilitate movement. It takes part in our memory, how we process information, and there is shrinkage, or actually the structure of the basal ganglia changes when a person is depressed. Lastly, one of the other components of the brain that you'll hear a lot about in the literature is the hippocampus. And this helps us with the processing of longer term memories. This structure of the brain is also smaller in those with depression. And the future growth of this can actually be impacted for those individuals that have more of a chronic presentation of depression. The other part, when we think about contributing factors are these brain changes, but also the neurotransmitters that, are in our brains and what happens. And so neurotransmitters help to transmit those signals between the brain cells, right? I broke it down into the three that are most often talked about. And again, a plethora of information in the literature on this, but for the sake of our presentation, I want to talk about dopamine, serotonin, and norepinephrine. So dopamine is the neurotransmitter that creates that positive feeling. It is associated with reward and reinforcement, motivation. Decreased levels of dopamine in the brain will lead to depression. Serotonin is that feel-good chemical, right? It is a busy neurotransmitter and does a whole lot. It regulates sleep. It helps with our appetite, sex drive, pain sensitivity, regulation of our mood. Decreased levels here, similar to dopamine, will lead to depression. Also, an increased risk for suicidal ideation when serotonin is low. Lastly is that norepinephrine, right? So this increases alertness, arousal, and attention. And when this is off as well, we also will see a greater likelihood of depression. In a couple of slides from now, I'm going to talk briefly about medication. And antidepressants and other medications are prescribed to help regulate these neurotransmitter levels and get those levels back to a level in which the person is hopefully functioning better. Another contributing factor when we think about what might cause or what might lead to an individual potentially having a diagnosis of depression, and that is early traumatic experiences. So these early experiences can impact how people respond to stress and fear, and also lead to depression later on in life. We call it childhood adversities, right? So these childhood adversities, if experienced, are predictive of a later onset of depressive symptoms. So when we're thinking about potential examples for this, we're thinking about parental neglect, abuse, or abandonment, harsh or unpredictable early environments. So I think about parental substance use. I also think about the potential of a parent that might have a mental health condition that maybe is not treated. I think about arguments, between parents and a child witnessing that. Potential DCFS involvement might be something that falls under this category as well. We think about family or environmental trauma as well. So losing one's home, if there's financial instability or uncertainty, those sorts of things would also fall into this category. If a child witnesses or experiences the death of a family member, that can also be a contributing factor, and also lack of a close relationship with an adult caregiver. So if the parent is not available and they don't have anybody else, such as a teacher or potentially like an aunt or an uncle, that is also a potential contributing factor for later onset of depression. What happens, in these traumatic experiences is that our nervous system over-responds. So it over-responds to stress, and we become desensitized, which impacts our ability to respond to stress later on. So this is definitely a huge predictor for the potential for depression. Next, of course, is genetics and family history, which we can't have a presentation and not talk about the potential for genetics, right? So some estimate, and again, lots of different information in the literature, but that genetics account for about 50% of the likelihood that one will experience depression. We talk about patterns of illness or heritability, and this determines what percentage might be related to genetics. So if there's a family history, an individual is 2 to 3 times more likely when compared with somebody without a family history to develop depression. Other genetic personality traits that might be a precursor as well include high levels of neuroticism. So again, that over-experiencing of negative emotions, perfectionism, negative thought patterns, low self-esteem. There's also a lot of studies out there that show when there is an identical twin situation, if one twin has depression, there is the likelihood that the other will have a 70% chance of also being depressed. This, of course, as mentioned, is an ongoing area of research. Next up is life stressors, right? We think about all of the ways in which stress presents itself and the impact that this can have on an individual. So I broke it down into severe and less severe stressors, but when we think about those severe stressors, these are the ones that are likely going to lead to a first episode of depression. So in relationships, divorce, infidelity, when we think about employment, termination, maybe unemployment, not being satisfied within your job, financial concerns, and bereavement, all of those would fall into the category of severe stressors. There are also less severe stressors, and when we think about these, not that they're any less important, but these might contribute to more of that recurring depression that we see. But if there's a breakup, if there's a close friend or family that's moving, and the potential of failing an exam would all qualify under that category. So we think more of the chronic versus the episodic nature of stress and the impact that that has on the development of depressive symptoms. Okay. I'm going to glean over this slide a little bit, one, for the sake of time, but two, because we've captured this throughout the presentation as well. But this is just another resource related to the medical conditions and the substance use factors that play a role in depression. We'll talk about sleep and poor sleep hygiene, but there's that chronic pain and also substance use, which has to definitely be taken into consideration when we think about the onset of depression. So now I want to go ahead and do a little bit of a breakdown. I want to talk about how depression impacts different segments of individuals. And I want to start with children and adolescents. And so there, of course, is likely additional information out there, but between 2016 and 2019, depression impacted almost 2.7 million children. I could imagine, again, because of the dates of that is much higher today. We also see that co-occurring anxiety and behavioral issues. Depression impacts how a child learns, how they behave, how they express their emotions. In younger children, we might see that separation, anxiety, potentially like refusing to go to school. In adolescents, we see that trouble actually getting to school, right? Getting into trouble at school as well. Increased irritability, maybe more eating disorder behavior and substance use. Over 35% of adolescents report a persistent feeling of sadness, and 18.8% might have an increased risk issues such as suicidal ideation. So definitely a segment of individuals that are definitely impacted by depression. High school students might be more likely to drop out. We also see those behavioral and emotional concerns where children might have to repeat a grade. And then I wouldn't want to close off this slide without talking about the protective factors, because that's equally as important, right? So what are the things that might protect or guard against the development of something like this occurring? We think about affection from caregivers to the children. We think about the traits of resiliency and curiosity and positivity, self-control. All of those are deemed to be protective factors when we think about the development of a depressive disorder for our children and adolescents. So I can't do a presentation, of course, without talking about a population that is near and dear to my heart. I am, as I mentioned, and Bree mentioned, the director of young adult programming over here at Compass, and this is a population that is absolutely impacted by depression. And when I reference young adults, we're really thinking about that segment of 18 to 25-year-olds. And why is this group majorly impacted? It's because this time is a time of huge transitions. And so I broke it down, in terms of the things that I see personally in my work here at Compass. But we see these individuals that are really, they're launching off to school for the first time. They are embarking on individuation and separation from their parents, likely for the first time. They're also navigating complex educational or employment systems. There's a high need of pressure to perform. There's also this stigma that, after high school, you're supposed to go to college. And I think for those individuals where maybe that's not the plan, or they don't feel equipped for that to be the plan, that can absolutely lead to significant stress and likely depression. During this time frame, they are reevaluating their values, right? So like, what is important? What was important for me growing up might not be important for me now, right? So there is that reevaluation of that. The discovery of hobbies and interests during this time, or as we sometimes see with our young adults, maybe an acknowledgement that there really aren't any, or what does it mean to develop a hobby as an adult, right? We think of somebody that maybe played soccer, all of elementary school, but now they're like, oh, like, I don't want to do that. Like, what do I do, right? So that can also cause an element of distress as well. The building of structure and routine, something that we often work with our young adults on as well, can be stressful. Creating meaning and purpose, financial independence, separating, as I mentioned, from their parents. I also want to just talk about the technological overwhelm and overload that this age group has to navigate. I think about, the impact of COVID, as I mentioned right below that, but 1 in 5 young adults referenced being impacted by COVID. And I think about, having to go and transition to doing, managing their education on the computer, right? I think about the prevalence and the impact of online dating and how stressful that can be for our young adults as well. Lastly, of course, for those that do decide to go to college, there is a limited limited resources on college campuses, which also perpetuates mental health and not necessarily seeking out support at that time. Depression in women, also important to talk about. So depressive episodes are more common in women, 10.3% compared to 6% in men. And for women, this often presents as sadness, worthlessness, and guilt. We also have to take into consideration those hormonal and biological issues that present for women. I think too about the pressure to achieve and to be successful that is prevalent with depression in women. Additionally, we see an increased rate of depression following the birth of a child, but also conversely, the individual that might be struggling with fertility or miscarriages, there is also the potential for that as well. We think about life circumstances and culture with women as it relates to depression. So unequal power and status, pay differentials, work overload, and also history of being the victim of abuse. The risk for suicide attempts for women is higher. However, the completion rate is lower when compared to men. Speaking of, so men, depression impacts about 6.2%, often presents very, very differently than it does for women. So it is often presented as irritable, impulsive, more angry, more reckless. They're also more likely to frequently abuse substances. Men are more likely to complete suicide and may show fewer warning signs as well. And the reason for this is because they typically opt to use more lethal methods. And so that is also a direct difference between women as well. And I think it's important to note, and again, an entire presentation could be done on this, but just the stigma, against expressing emotions or seeking help that plays out for males, right? This is a wonderful quote from Dr. Angelino, chief of psychiatry at Howard County. But he essentially said, like, we've taught boys that they don't cry. So instead of crying, they get angry or they get threatening, and it's more difficult for them to express their emotions. And oftentimes that's where we see the development of a depressive disorder. Okay. Moving along, depression in older adults, right? This is also another category of individuals that is very important to talk about. 65 and up, we're really seeing depression in about 1 to 5% of the elderly, but this can increase for those that are in home health care. We're seeing a lot of sadness, grief, for this age group, navigating medical issues, the loss of a spouse or a partner, end of life decision making. And 2 factors came up pretty frequently within the literature, and that is of loneliness and social isolation, both of which are huge contributing factors for depression in this population. Additionally, we see with these individuals memory loss, mobility issues, hearing and vision issues, of course, a higher risk for dementia, anxiety, inflammation, etc. I did put 2 resources at the bottom, which I just think are really great. There's one called an Elder Care Locator, and then also one through the National Institute on Aging regarding activities for older adults to participate in, hopefully to mitigate some of the potential for the development of depression. So again, 2 great resources down there. For the sake of time, this is in my resources, so I'm going to skim past this slide, but it's actually a great reference on what to prepare and how to ask the questions when somebody is either going to their medical doctor, a psychiatrist, or a therapist about depression. And it's a really useful resource, so I wanted to make sure to include it in there. So now we're going to spend the last bit of time talking about treatment interventions, right? And so I want to talk really briefly about medication and other things that can assist those individuals that are diagnosed with depression. So when we think about medication, we break it down into 3 categories. There are the SSRIs, the SNRIs, and then the atypical class of antidepressants. So those SSRIs, I just want to start there. It's safer. They're often the starting point when we're talking about medication and depression. And essentially, they work by increasing that serotonin in the brain. And remember, an individual who is experiencing depression has lower levels. So that is why medication can be an effective treatment intervention. That first line, that SSRI, they do have fewer side effects. We're thinking about Prozac, Celexa, Lexapro. Those all fall into that category. And then there's the SNRIs, and then of course the atypicals as well. When an individual might experience treatment-resistant depression, so say potentially, the medication is not working, they might look into, or their doctor, of course, might recommend ECT or electroconvulsive therapy or transcranial magnetic stimulation or TMS. And essentially, they're different, but electrical currents are essentially passed through the brain. And these are helpful interventions for those that might be higher risk or have a poor response to medication. TMS actually has less side effects than ECT and is one that is definitely making its way more commonly in the literature today. I want to talk about a few other ones. So movement, light therapy, and alternative options. All of these are really helpful interventions when we think about supporting those individuals that have depression. So movement, this triggers those feel-good chemicals in your brain. I'm sure you've heard about the runner's high, that release of those endorphins. Movement also improves self-esteem, productivity. It helps us to connect with other people. It also improves sleep quality. And the Mayo Clinic recommends 30 minutes, at least 3 to 5 times per day, 3 to 5 times per week, not day, in which an individual should take part in this really to see an alleviation of symptoms. Additionally, there's light therapy. This helps with folks that might be diagnosed with seasonal affective disorder. You might have heard of a light box or a lamp, which are used to regulate that melatonin. They recommend 30 minutes a day for this. There is a pretty decent success rate of 40 to 60%. There's a great resource through the Center for Environmental Therapeutics, which has a lot of information about light therapy and the benefits of it as well. Of course, there are alternative options: yoga, tai chi, acupuncture, massage, music or art therapy, spirituality. All of those can be really helpful when we're putting together a treatment plan to best meet the needs of those with depression. I'm going to talk a bit about the continuum of care. So when we think about an individual who requires support for depression, right before this arrow, so even before outpatient therapy, I'm thinking of the individual that presents to their medical doctor. I'm feeling fatigued, I have a lot of body aches, etc. Through further assessment by the medical doctor, they might determine that that individual needs, and could benefit from an outpatient therapist. So that is typically 1 to 2 times per week individually that an individual would meet with their therapist. Now, say that is attempted for some time and it's not proving to be enough support. Maybe there is not as much alleviation of symptoms. The individual might be a little bit stuck. There might be a risk issue that perpetuates the need for a higher level of care, is what we refer to it. And that's where my work comes in, in an IOP or a PHP type of setting. We consider it one step below inpatient hospitalization. And I'll talk a little bit briefly about what those levels of care are. Inpatient hospitalization is obviously above a PHP. That is really for those individuals that are at the highest risk. There are safety concerns and those sorts of things. And then at the other end of the spectrum is the potential for residential care. This sometimes is a referral after inpatient if PHP or IOP is not enough, but it can be a longer term 24/7 type of support that could be helpful for individuals with depression. So for the sake of time, this is the breakdown of the difference between PHP and IOP, but essentially it really is to provide that short-term stabilization and skill building for those that are really in need of more intensive care. The hope is to actually avoid the emergency room if possible, and it provides upwards of 20 to 30 hours of weekly support. And so a great option for individuals that might not be making as much progress at an individual outpatient level, or might be stepping down from the hospital to this level of care. So when we think about treatment in general, research shows that the most effective form of support and intervention for individuals with depression is the combination of therapy and medication. And so I want to talk about two different potentials for therapy, one of which is CBT and the other of which is DBT. And I'm sure folks have heard a little bit about these, but the first is cognitive behavioral therapy. It is brief, it is goal-based. It really helps us to reduce those negative and unhelpful thoughts. We talk about the cognitive triangle. You can see my interpretation of it over there. We start off with an event, something happens, right? Something is happening to elicit the thoughts that I'm having, right? I tell myself something. So whether I failed an exam, right? And I think, oh my goodness, like I'm such a failure. And then I feel something, right? Like I feel sad, I feel disappointed, embarrassed. And then I do something, right? So maybe because I failed, it's prohibiting me from taking the exam again, or, something along those lines. So when we think about an individual that is struggling with depression, we really are looking at the impact between thoughts, feelings, and behaviors. And that's where CBT really comes in. I put a bunch of cognitive distortions and cognitive restructuring on here as well, which is just, again, really helpful when we think about the impact of these, distortions on our general mood and functioning. So CBT really helps to ask the question, are my thoughts helpful? Are they accurate? And then really to help the individual develop skills to start to reframe and challenge and replace those negative thoughts. And then there is dialectical behavioral therapy, another very common treatment intervention for those that are having severe emotion dysregulation. It talks a lot about the dialects, right? So that two opposing things can be true at the same time. The goals of this treatment modality are really to move out of that black and white thinking, immerse ourselves more in the gray, to be flexible and adaptable, and to really act from a place of value. There are 4 different tenets to DBT. Again, an entire presentation could be done on just that, but there is mindfulness. I'm going to go to my next slide because it breaks it down a little bit more. Mindfulness, so choosing to pay attention to the present moment without judgment. I listed a few different skills there that could be helpful. Distress tolerance, right? When we're thinking about this modality of intervention, this is really helping us to cope with a crisis without making our situation worse. So grounding, self-soothing, right? Identifying the pros and cons, being willing to address what's going on. There's also the tenet of emotion regulation, and this helps to bring balance. It really allows for us to be curious and to seek understanding. So we're talking about doing things in the opposite direction of what we might be feeling, right? In order to dislodge some of those stuck patterns, creating cope ahead plans, like what's worked for us and how can I incorporate this in the future. Additionally, the last component of DBT is interpersonal effectiveness. So how do we use this skill set to get our needs met while preserving our relationships, also in the means of self-respect? So lots of information that could be shared on DBT and CBT, but definitely helpful when we think about the interventions related to depression. I want to just talk briefly about self-care because this is also so vital when we think about the impact of self-care on mitigating depression. So when we talk about self-care, we're talking about boundaries. If you're feeling overwhelmed, saying no, resting, regrouping, recharging, right? Journaling. I put a really neat reference on there that has a lot of journal prompts. Finding a support group can be really helpful. Of course, there are a lot within NAMI. There's the Depression and Bipolar Support Alliance as well. It's important to be intentional about relaxation and the management of stress, avoiding making big decisions when you're feeling depressed. I put a few different apps on there that have been proven to be really effective. There's the Calm app. There's a great one through UCLA that's a mindfulness app. The Dailyo Journal is a great way to track day-to-day mood and functioning as well. Also healthy eating habits, sleep hygiene. They talk about a low sodium diet and how that can be helpful in terms of mitigating depression, and also ensuring that you're getting 7 to 9 hours daily. Also decreasing screen use, which I could talk about that forever as well. But really being intentional about that time right before bed. So 30 minutes before bed, not being on your screens, but incorporating something of a replacement activity, such as a mindfulness activity or something that you can do instead. I'm almost done. I want to talk just briefly about how to support a loved one, because I think this is so important, and it really ties in to how we started off our presentation today, with the impact, that residual impact that depression has on most all of us in this virtual room, whether we work and provide services and support to individuals, whether we have a loved one, a family member, a spouse, a friend that is going through depression. How do we support them? And so it's important for caregivers or therapists or whomever you might be to learn more about it. There are several resources available. Also, to acknowledge and express your concerns to your loved one, right? Share with them, I'm feeling concerned, you seem off, right? Having that conversation and not being afraid to stray away from it. Ask what they need, right? We might assume that somebody needs something, and that's actually not what is needed. So how do we ask them what is needed, and how do we actually hold space, right? Creating space for those that we love as we support them if they have depression. Are we providing hope and optimism, right? Are we focusing on positive reinforcements and strengths? That's also really important when we think about supporting a loved one. It's also important to keep a sense of humor, try to be lighthearted, right? Incorporate that wherever you can. And as I mentioned, at the beginning of the presentation, just being aware of risk. There's that 988 crisis hotline number that is vital as well. And lastly, I always say the caregiver needs caring too. So if you are somebody, in this virtual room that is taking care of somebody else that is struggling with depression, making sure that you're seeking out your own support, because that will be imperative as you navigate your relationship and your care for your loved one. And then lastly, I put a bunch of resources on here. So I'm hoping that these are helpful. There are some that we weren't able to get to, but definitely several pages of resources for your reference. And as I mentioned, there's so much information on depression, but my hope is that, in this hour that we spent together, you're able to glean a little bit more of an understanding of the underlying issues that present itself, the specific disorders related to depression, and of course, treatment interventions and skills that can potentially be helpful as you think about the future.
Thank you so much, Dr. Brankin. That was so informative. And, as a person who does have depression and is on medication and does go to therapy, it's very refreshing to talk about this and openly talk about this, right? We want to make sure that we're normalizing this conversation, because it's very real. And I really appreciate the resources that you provided as well. That's something that I am more than happy to share with you all when we close, probably tomorrow at some point. But I do know that some of our guests may have some questions. So if we could get that conversation started, let's do it. We have the Q&A feature in the toolbar at the bottom of your screen. If you want to type in some of your questions, I will read them and we can get them answered. You can also make your questions anonymous too, if you prefer to select that feature. We do have one question. It says, when and why are atypical medications prescribed? Are there risks involved in being in these medications long-term?
Such a great question. And I think so important for me to stay in my lane and my education, related to that. But I do want to provide an answer. And essentially what that is when we think about those atypical medications, it really is they're utilized when the other categories might not be working, right? And so for this question in particular, regarding risk and what potential medications might be used, I would encourage that individual, potentially to seek out the support of like medical guidance or, from their psychiatrist as well. But definitely that is used, when we think about the SSRIs, those are the first line of defense, right? The most effective typically, and the safest, and then we kind of work our way down. So definitely, for those that might not have as best of a response to the other two categories.
Thank you, Dr. Brankin, and thank you for asking that question. Any other questions from our audience? I do have a question for you, Dr. Brankin.
Yeah.
So you mentioned 3 different types of therapy. So there was CBT, DBT, and I'm blanking on the last one, TBT?
So CBT and DBT were the ones that we mentioned today. Absolutely.
So my question for you is, are there therapists or psychologists that are out there that could provide both types of treatment, or is it one or the other?
Such a lovely question. And typically, there are individuals that might specialize in providing dialectical behavioral therapy, which is DBT, or they might practice from more of a CBT type of lens. But often you see a little bit of a blending of both of them. They are both evidence-based interventions, meaning there's research to support their effectiveness. And so, for instance, here at Compass in our daily programming, we utilize both. So there are groups that are related to CBT and there are groups that are related to DBT. All of which are affected. And so for an individual that might, want one over the other or want to, something along those lines, I would encourage them to have a conversation with their therapist about that. But definitely there is often a blending of both of them.
Great. Thank you so much. I appreciate it. Any other questions from our audience?
Maybe everybody's sleepy on this Wednesday.
Oh my goodness, right? It is. It's like so nice outside too. So thanks for coming.
Yes.
It's like getting outside, and man, it's been such a great day. We do have a question.
Perfect.
How do you diagnose bipolar depressive versus unipolar depression? Excuse me. Oh my goodness. Is the thinking still that medications are quite different depending on which type of depression it is?
Yes, and I think that's a little bit of a layered question, right? When we think about the bipolar disorders, which is really like a whole other category, right? And so when we think of bipolar, we're thinking of exactly that. We're thinking of a depressive episode, oftentimes, sometimes paired with a manic episode. And so treatment interventions, medication plans, all of those things might look a little bit different for an individual that has that. When we're thinking about depression and assessment in general, we are often like ruling that out, right? We're making sure that we're looking for symptoms. We're making sure that potentially that the symptoms don't fall into a bipolar category. And then a treatment plan is created from there based on symptom presentation.
And to bounce off of that, we are in March, we are having a guest speaker come and speak on bipolar disorder. So that will be in the month of March. So it's
what a beautiful transition.
I know, right? She read my mind.
Perfect. And I think, similar to that, I mean, it could be an entire presentation just on that segment of disorders, for sure.
Totally. Yeah, you got a lot of information in there in 1 hour. Super impressed. That's great. Okay, any other questions from our guests? Thank you for your participation and asking some of those very valid questions. We have another one. When you showed the brain, are there scans that show this?
There is, yes, absolutely. That's a great question. There is so much research out there related to brain activity, neurotransmitters. There is also activity on whether or not, this is the area to focus on. And so there you'll find lots of different camps when you think about that. But yes, there has been brain activity that has been shown in different parts of the brain.
Thank you so much. All right. Any other questions? There we go. Can you speak to motivation and depression?
Hmm. In general, yeah, I could provide a little bit of information just on, and I'd love a little bit more in terms of what the individual might be asking, but we really see that as a struggle with individuals that are diagnosed with depression or have depressive symptoms, right? Is the ability to be and to motivate themselves. And sometimes we see it with the simplest of tasks that we, as somebody that might not have depression, for instance, making their bed or, making a meal at the end of the day or going grocery shopping. Sometimes motivation for those seemingly more simple tasks feels incredibly overwhelming and daunting, right? Additionally, like decision making, there's often, as I mentioned in the presentation, that decision fatigue, which comes up, which also because there's, perhaps a lack of motivation or an inability to make a decision, that often plays out too.
Absolutely. I was smiling and nodding because that
Yeah,
is definitely a symptom that I
yeah,
have some experience with. Thank you for
absolutely.
asking. She had a follow-up to that question, and the follow-up was, how do you motivate someone who has depression?
Mm.
Good
I think
question.
that's the question of the hour, right? And I think that really comes down to individual work, right? Figuring out like what are the blocks, what are the barriers. I often think too when working with individuals, like how are we breaking it down into manageable steps? Like maybe going to the gym or going to the grocery store it feels insurmountable. It's not something that they can imagine doing, right? So how do we break it down? And so I think about like, okay, maybe today they're just going to create their list for what they need to get at the grocery store, right? Or maybe they will go to a smaller grocery store than like a larger one, right? Thinking about ways that they can make it a little bit more manageable. And when we make it more manageable and we break it down into steps, the individual is also going to feel a little bit more success, right? Like, okay, like I was able to create my list. Now let me try the next thing, right? And hopefully that builds some momentum related to motivation. The other thing too that we talk about, which is a skill, but it's called opposite emotion to action, right? And essentially what that means is like, how are we acting in accordance with the opposite of what our brain is telling us to do? So for instance, the example I often give to my young adults is right now I'm having the urge to stay in bed. I don't want to get out. I don't want to go to program. I don't want to do anything. I don't want to see my friends. But what's a small step in the opposite direction that we can take, right? Again, breaking it down. Maybe I'm making sure that my phone is across the room. And in order to get to my phone, I have to get out of my bed. Or I start by taking the sheets or the comforter off. I put my feet on the floor, right? Those sorts of things, smaller steps in the opposite direction can also be helpful.
Yeah, thank you for that. And as you were speaking to thinking about how do you work with somebody who doesn't have the motivation, right? I remember you speaking on, curiosity and compassion, right? So being curious as to what they need versus, what you want to get done in that moment, can really make the person feel more confident.
I love that. Or even like, how can I support you, right? Like I see that you're having a hard time. How can I help, right? Like, what do you need from me? I think that's an absolute wonderful way to start the conversation.
Yeah, totally. Okay, we got another one. Okay, they're rolling in. Let's see. If you have depression long enough, can it become part of your identity where you begin to feel a lot of ambivalence about getting better and taking steps to live a fuller life? How do you surmount this?
I actually love that question. I think it's really great. And I think it's a complex answer, right? I think the longer perhaps, somebody has a diagnosis of depression, perhaps it's more chronic, they might feel a little bit more stuck, maybe movement isn't feeling as much as they want, perhaps treatment interventions haven't been effective, right? And so what we see, is that feeling of stuckness. And I think that can be, really difficult for sure. I also think it's important to share that for some, there is that fear of getting better. And I think we have to name that and acknowledge that, right? Maybe it has been part of who they are, right? Like I've been depressed for as long as I can remember. Like what in the world would it feel like if I wasn't depressed, right? When I work with my young adults, I often talk about that too, is like, how would their role in the family change, right? Like would expectations maybe look a little bit different, right? Might they be expected to get a job or do something along those lines? And that feels really scary and overwhelming. And so is there then the likelihood that they stay kind of in that stuck space because it's coming from a place of fear about like what happens next and what would it mean if I didn't have this and if I didn't feel better.
Great answer. All right. Next question says, can a person's brain or body get used to a certain medication and no longer have the same effect as it used to?
I mean, I think that is absolutely, when we think about medication or we think about individuals that have been on medication or the same medication for quite some time, and maybe they're not seeing the same effectiveness. I think it's always worth a conversation with your psychiatrist or your medical doctor about that, right? Like, is there something else that we can potentially try, right? When we think about antidepressants, it usually is like that 4 to 6 week window, right? Before we see any sort of like relief. And so psychiatrists or doctors, they're going to wait that time frame to see like what's happening. But if an individual maybe has been on the same med for years and they're not feeling that it's as effective, that absolutely, I would highly encourage, folks to advocate and to assert themselves to their treatment team.
Yeah. I love that. Advocate for yourself. That's
Yes,
great.
advocate.
All right, next question. How do you choose a program that is best suited for your young adults suffering from major depression?
Program as in like higher level of care? And I can't see the questions, I apologize. So
Okay.
is
I
that
would assume so, yeah.
okay?
It seems like, thinking what treatment option is what
Ah,
I'm gathering.
for sure. If, say for instance, and this is obviously hypothetical, but if, the individual is already seeing a therapist, I would absolutely seek out their guidance related to, treatment programs that might be the best fit for them. I also think, doing an intake, right? Starting there and like looking at the programs that are in the area, doing some research online, seeing what they might, certain modalities that they work with, populations that they treat. And again, that goes back to like being an informed consumer and finding like what might be the best fit. And so looking at it that way to gather some information, calling places, talking with the directors of the program. I talk with folks all the time, about programs and, just for them to determine if it could be a good fit. So I think the answer to that, gathering more information, doing research, looking into potential intakes could be helpful. For young adults specifically, I think also making sure that there is like a young adult program. I think that's so vital. Sometimes our young adults are clumped into an adult category and they are adults, right? I don't want to negate that. And like there is something very specific to that age group. And so that also could be a factor that could be helpful when looking for programs.
Absolutely. Next question. Is it possible to emerge from persistent depressive disorder? What does it mean to recover from PDD? How does someone with PDD overcome the fear of getting unstuck?
Such a good question. Yes, I mean, remission is possible for any of the depressive disorders and really is a combination of that treatment that we spoke about, medication, also paired with, therapy interventions, those sorts of things. When we think about chronic, dysthymia, which is what it used to be called, for instance, we're really looking at that 2-month window with no symptoms. And so I think for the individual just to be, tracking and, how am I feeling, doing a daily check with that. And I think it goes back to what we talked about a couple of minutes ago of like, also like checking in with themselves about like, is there that fear about like what would happen if I didn't have this, right? Am I seeking out all of the resources and support that I need, even if it's in my courage zone? Because I think that's a big one too, is that sometimes we're, for lack of better words, comfortable because this is what we know. But that could also be a helpful way to navigate it.
Absolutely. All right, next question says, my daughter went off her depression medication for 2 days and fell into a deep depression. That was relieved when she went back on it. Does this mean that if she were off the medication, she would be that severely depressed? Or is it because she didn't treat it, she didn't go off it properly?
One, I just want to acknowledge like how difficult that must be for that mom, to watch their daughter suffer. And so I want to start there for sure. And secondly, I think these are great questions, too, for the attending psychiatrist, right? Like, is there like if somebody is off of their medication for 2 days, they might feel something, they might feel off, they might experience, a side effect, something along those lines. And consistency of taking medication is key. And so, I would also potentially ask like maybe what got in the way of the missed dosages too. Is there a way, sometimes with our young adults, we do daily trackers, we have pill boxes, is there a way that we can maybe avoid that in the future? But I think bringing up those questions to the treatment team could be, super important.
Next question. With such a mental health provider shortage, what do you suggest a person with depression do while on wait lists or in the process of finding other mental health options?
I want to preface this question by saying this is like the real deal. It really is across the board. And I would say, looking into like if some place is waitlisted, is there someplace else, right? As much as there's one, is there another place that can go? There are places that don't have wait lists. So is there a way to look into that? Again, if there's an outpatient team, can they connect with their providers to see what resources might be available? And I also think about like advocating, for oneself. I think about support groups. I mean, NAMI, has a ton of them. There is the Depression Alliance as well. There's tons of things within the community as another means of an intervention that could be helpful if there are wait lists involved.
Thank you so much. Yeah. And, as Dr. Brankin mentioned, we do have support groups. They are free of charge. I am going to type my email into the chat box for you. If you would like to reach out, we can get you squared up with a support group that fits your needs.
Wonderful. And I did put a few different ones in the resources as well as things to look into.
Thank you. That's super,
Welcome.
super helpful. I'm excited to explore it myself. One says, is there contagion? I think I'm pronouncing that right. Is there a contagion effect of being in treatment with others who are also suffering from depression, like there can be with eating disorder treatment centers?
I think that this is a loaded question. I think actually one that we sometimes hear, potentially from like concerned parents or, something along those lines. Like if my child is coming in, this is how they're presenting. Is there the potential that they're going to get worse or they're going to pick up on, behaviors that they might see within the setting that they're in, right? And, I think it's hard to tell, versus like a case by case kind of unpacking of that, whether or not that is. I think, peer pressure can be the real deal. And, I think that's why, like in these types of settings, there are treatment teams to help support. If something is coming up, like can the team, mitigate and talk it through? Is there a way to like involve parents, which I think is absolutely a huge aspect to that. And so I don't think that there's a solid answer to that. And I apologize. I think it is very case by case.
Definitely. Okay, next question says, are there support groups for young adults with depression that are not related to substance use recovery?
There are a bunch within the community. And I would just encourage folks to like, look, I'm also more than happy to pair with you, Bree, to give some additional resources as well. But there are plenty within the community. There are also, not necessarily mental health focused, but sometimes we talk about meetup.com. If connection is something that folks are struggling with, if they're having a hard time building structure or getting out of the house, is there an activity at the library they can participate in? Or, is there a hobby that maybe they've been meaning to try that they can connect with like-minded individuals about, right? That sense of connection and community is equally as important, to specific mental health treatment. So to answer the question, yes, there are a ton of resources specifically for young adults. If the young adult is on a college campus, I also encourage folks to look into resources there. I think while they can be limited, I think sometimes they're also overlooked. And so connecting with the counseling department to see what resources might be available in that realm as well.
Absolutely. And really good news. We are also in the process of launching a support group for specifically young adults. We are hoping to launch that sometime this spring. So around April, May, go on our namiccns.org website, and we should be getting that rolling. We're hoping it will be in person, either in the Des Plaines area or the Evanston area, where our college campuses are. So just be on the lookout for that. Sorry, it's not right away, but it is a need that we are seeing, that we are trying to make moves to provide some support.
I was just going to say a way to address the need and, how much of an impact depression has on the young adult population. It's pretty profound. So I love that group is coming. We'll be on the lookout for it too.
Thank you. Yeah, we are very excited about it, because you're right. I mean, it is very prevalent in that age group.
For sure.
How did you, Bree? Oh, question, Bree.
Good.
How did
Passing
you,
the torch.
Bree, how did you learn to manage your depression? It took some time, right? It was a lot of trial and error. A lot of mine was environmental and biological factors. And so when I went to my doctor, I advocated for myself. I tried a multitude of different medications. I was able to interview my therapist. So I found somebody that was just perfect for me. And I've been with her for about 3 years. And, as Dr. Brankin mentioned, right, just having, those everyday self-care strategies, right? So waking up, going for a walk, right, within the first hour of my morning, exercising, trying to eat, a well-balanced diet. Screen time is huge, right? So trying to not be on my phone so much. So, there's things that work and there's things that don't. And, recovery is not linear. So there are days that are harder than some, but I'm very happy to say that I am in recovery, and, things are going very well. I appreciate that question. That was very nice. Thank you.
I appreciate your sharing of that. Thank you.
Of course. Yeah, of course. Man, we got to reduce that stigma. Let's normalize
Yes,
this.
so true. So true.
Hilarious. Okay, so I think we are almost out of time. I really appreciate all of your questions, and of course, Dr. Brankin, thank you so much for being with us and sharing all this information. It was so important, and I'm just very excited to have this as a resource for those who are in need. So if you did enjoy tonight's program, you can find more information on our upcoming events and our webinars at our website at www.namiccns.org. This presentation will also be uploaded to our website as well. So if you'd like to rewatch or share, please do. Our next program will be held on March 13th. So please mark your calendars from 7 o'clock to 8:30. So same time, where Dr. Juliet Spellman, who is a mental health professional from Northwestern University, will teach us what we need to know about bipolar disorder. Our March webinar is going to be sponsored by the Glenview Public Library. We're really excited for these new sponsorships that we are obtaining. Once you log off, you will see a short survey. please, 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 I'm begging you, please fill it out. Not only does it allow us to know how we can improve, but it also provides us with the data that we need to write grants and raise money to continue providing our programs for free to our community members. So please, it only takes a couple minutes. It would be greatly appreciated. And we do appreciate your presence tonight. Thank you for spending this evening with us, and we look forward to seeing you all again at a future NAMI CCNS webinar. Please take care of yourselves and each other, and we will see you in March.
Thank
Bye,
you.
everyone. Thank you, Dr. Brankin. You're the best.
Absolutely.
Have a great night.
You too. Thanks, Bree.
Of course, of course. I'll be emailing you later.
Okay, now I just have to figure out how to get out of this, right?
I will end it. Bye.
Thanks,
Have a good
Bree.
night.
Bye.